Okay, so we look at therapies that are cognitive now. And if you think about when we talked about a lot of the problems that we have, abnormal psychology, there's a lot of cognitive aspects to it. So even when we do, anything that causes the disruption, it changes our way of thinking. So cognitive therapy looks to change the way we think about things, because often when we have difficulties, it's because our cognition is not working properly. Now, rational emotive therapy is an idea of looking at challenging those ideas that we have and changing them and challenging the thoughts that we have. Erin Beck is a very famous researcher when it comes to depression. And we have Beck's depression inventory, and he's come up with the rational emotive therapy where we really challenge those ideas that we think. People think in absolutes, so he changes that. So it might be along the way of, like you're thinking about I'm such a loser. Well, what is a loser? Write down the definition of a loser. Is that what you actually meant? And it might change the way you think about things. Cognitive behavioral therapy is a combination of cognition and behavior. So what we'll do is change the way you think about things, and we'll also change the way you behave based on operant conditioning, classical conditioning. This is a really common thing in phobias, like on an elevator. We might give you strategies to think differently about getting on an elevator and ways to deal with that anxiety. And then we'll put you in the position, in exposure therapy where you go up an elevator. And once we do it, then all of a sudden this stuff dissipates and we don't have the problem anymore. So the cognitive therapies work on, like the thought processes. We talked about this before, but, you have a lost job. You lose your job. You have internal beliefs. I'm worthless. It's hopeless, which leads to depression. As opposed to, giving internal beliefs, like, well, my boss is a jerk. I deserve something better. That leads to better coping strategies. So we try to change the way you think about something in order to change how these things affect you. Now, rational emotive behavior therapy is Albert Ellis's design, and it really challenges irrational thinking, and it really changes the way that you think about your behavior, and it's very it's aggressive. It's very much like, you said this, but you actually mean this. So it's a little more direct than it is Erin Beck's ideas. However, it is a very good way to change the way somebody thinks about something. And often when we have problems, if we can change that, then we lead to better outcomes. So Erin Beck's therapy for depression, includes, stopping those catastrophizing beliefs where everything is a catastrophe. It's where we need to be more in the moment, and it reveals those irrational thinking behaviors, and it's a lot gentler than the rational emotive behavior. And again, the cognitive behavioral therapy combines the cognitive and behavioral therapies, so we change the way you think and the way you behave, much like the example I gave you earlier. So when we look at the different types of cognitive therapy techniques, we look at, the aim of a technique. We want to reveal your beliefs. So we question your interpretations and we rank your thoughts and emotions. So the therapist's directive is, like if you have interpretations, we explore your beliefs, revealing those faulty assumptions that you might have. That, for example, you feel like I must be liked by everyone. Well, no one's liked by everyone, and it's okay if some people don't like you. Or gain perspective by ranking your thoughts and emotions from mildly to extremely upsetting. Test beliefs is another goal of the cognitive therapies, another aim. In this case, we want to examine consequence. And we look at difficult situations. We assess the possible consequences and challenge your faulty reasoning. Now, to decatastrophize, you know what I'm trying to say, those things, we work through the actual worst-case consequences of the situation you face, and it's usually not as bad as you imagine, and then we determine how to cope with the real-life situation. So kind of inoculation training would be like you're taking an AP exam. Well, what's the worst thing that can happen? You don't do well on it, so you have to take first-year psychology. And you know what? The sun still comes up the next day. It's not that big a deal, so we can relax a little bit. Then change our beliefs is the other aim of these techniques. We want to take appropriate responsibility. Challenge total self-blame. Is it all our fault? Okay, and the negative thinking, noting aspects for which you may be truly responsible as well as aspects that you aren't responsible for. It's kind of like our circle of influence. There's only certain things we can influence. If we can't influence those things, we shouldn't worry about them. And then also our technique with changing beliefs is to resist the extremes. Develop new ways of thinking and feeling to replace maladaptive habits. For example, change from thinking, I am a total failure, to I got a failing grade on that. Okay, and often that's a lot easier to deal with. It's like, a huge balloon of problems that we come up with, as opposed to let's deal with the right here and the right now, and this is what the problem is. When we compare the modern psychotherapies, we have the psychodynamic therapy, which is based on psychoanalytic therapy. And these are dealing with unconscious conflicts from childhood experience. And our idea is to reduce anxiety through self-insight. When we understand these things, we can deal with them a lot better. And the technique, of course, is to interpret your memories and your feelings. Now, client-centered behavior is a humanistic idea, and we look to barriers to self-understanding and self-acceptance. The aim is to enable your growth via unconditional positive regard, genuinity, and empathy. And the therapist uses active listening, and they reflect clients' feelings. And then eventually, through client-centered therapy, we can come up with our own ideas of what our problem is. Behavior therapy looks at dysfunctional behaviors. And the idea is to relearn those adaptive behaviors and extinguish the problem ones. So we use classical conditioning, exposure, aversion therapy, or operant conditioning, as in the token economies. Cognitive, we look at negative self-defeative thinking. How do we think? And we promote healthier thinking. And the way the technique works is we train people to dispute negative thoughts and attributions. Cognitive behavioral, self-harmful thoughts and behaviors. We promote the healthier thinking and adaptive behaviors. And the idea is we train people to counter self-harmful thoughts and to act out new ways of thinking. Now, group and family therapy, which I haven't talked a lot about, group therapy sometimes is something that it's a lot cheaper than individual therapy. And it works usually in a relationship situation. You think of somebody with depression, and one of the things we know is there's a hereditary factor. So let's say a mother, in a family of 4, has a problem with depression. It changes her role in the family. It changes everybody else's effects. So sometimes it's good to work on the relationships of the whole group to treat the one person. So the technique is develop an understanding of family and other social systems and explore the roles and improve communication. And again, we're talking about group therapy. This is not appropriate for all things. We don't want a group of depressed people sitting around talking about how depressed they are and how bad the world is. But often group therapy can lead to ideas where I'm not alone. Other people feel this way and gain insight through other people. The family therapy is usually more what we would use. We have bad relationships in a family and we try to make it work, which may lead to some kind of, abnormal psychology in, say, an offspring. And so if you have depression and a lot of the roots is how your family interacts, we need to change that whole family interaction to treat you. Okay? So the self-help groups and stuff, they're all really good. However, they have certain limitations and stuff. If we have behavioral issues, we're afraid to go on an elevator. It's good to be around a group that feels the same way and can sympathize with you and associate with what you're saying, and also can offer support for you when you're doing the behavioral aspects of this therapy. So when we evaluate these therapies and the prevention strategies, here's the outcomes. Have a look. Is it effective? We ask clients about it, and clients will probably give a better indication that it works better than it actually does, because clients want to get better. They've paid money. They've, decided to take this route, so they're going to have a bias that way. Clinicians are also going to have a bias. They're going to have a confirmation bias, thinking they're great therapists. They're going to forget about cases that didn't go well, and they're going to remember the ones that did go well. And it's important to mention at this point, psychiatry and psychology is just like any other medical experience. We don't always win. The outcomes aren't always great. But when we look at outcome research for the therapies, we look at meta-analysis. And meta-analysis is taking a whole bunch of research, a whole bunch of studies, and putting them together. So, like one group will study the effectiveness of research or of therapy, and another study does that. We'll take those results and put them together. And usually it's in a whole bunch of studies. And through meta-analysis, we have found, when we look at this graph here, that the average untreated person, compared to the average psychotherapy client, there's about an 80% of untreated people have poorer outcomes, which is fairly significant. So the therapies do work, despite what some might tell you. It doesn't work for everybody, and we need to look at actual evidence of this. And the evidence suggests that yes, it is quite viable and it is important. So the relative effectiveness of different therapies, we look at evidence-based practice. Okay, if we look at the stool down here, it includes patients' values, characteristics, preferences, and so on, the clinical expertise, and best available research. And from this, we can put together a program or a therapy for that individual that is going to be the most effective. And we base it on research. So that is how we decide which types of therapies are best for some, but maybe not best for the other people. When we evaluate these therapies, we can look at things like eye movement desensitization. This is the idea: eye movements will dictate what you're thinking, and we can train the eyes to, go into a more optimal way to think about our past, or, with our memories and change things. However, when we find it really doesn't have much of an effect, this type of thing. This is an alternate type of therapy. We look at light exposure therapy, which seems different too. This is, usually used to treat SAD, seasonal affective disorder. And we find that when we introduce them to a light that emits the proper rays, that it does seem to alleviate their seasonal depression, usually in the winter when it's darker. And what's really interesting is we found if we just shine that light on the back of your knee, it works just as well as if you're immersed in it. So it does something. It stimulates some kind of hormonal issues that really help you deal with that depression. Now, one of the ways we can look at this is if we do a journal search of articles about eye movement desensitization and light exposure therapy, we will find there are far more articles on, or journal entries on light exposure therapy. Now, these are peer-reviewed. They're based on research from other people. When we look at eye movement desensitization and other, forms of therapy that maybe don't work, and we compare their journal entries, maybe 100, to website, through a Google search, just websites, there might be millions of websites, but that really means it's just a layperson that is promoting that idea. But when there's very few journal articles, it means that there really wasn't much there to create further studies, so it probably doesn't work. So what's common among all the psychotherapies? They seem so different, but you know what? They all give hope for demoralized people. They give the patient a new perspective, and also they have an empathic, and a trusting, caring, and relationship, which all comes from the therapeutic alliance. The therapeutic alliance is the idea that we have this one person that we trust, and it's the relationship between the patient and the therapist, which really adds to the hope and all the other things. Okay, the culture, gender, and values in psychotherapy, there's similarity between cultures. The therapies seem to work. A lot of the behavioral problems, abnormal behaviors are similar. But when we look at SAD, for example, though, it only exists really more in North America, than it's way more prevalent than in Iceland, where there's tons of times where there's no light. What could that be? Could it be just that they're isolated, their genetics are isolated, so they stay there? So it could be. And there are differences. Depression and schizophrenia are common amongst all cultures, but other disorders are different among each culture. So when we look at therapists and their training, clinical psychologists, most of them have PhDs, okay, and they're trained, so they have their doctorate degree. They're actually trained in clinical psychology, clinical therapy, so they can diagnose and they can help that person out. Psychiatrists are different. They specialize in treatment of psychological disorders, but they have not all had extensive training in psychotherapy. It's a medical degree, so they can administer drugs. They can prescribe drugs. And so they tend to see people really with the most serious problems that we need some kind of biological medication for. Most have their own, many of them, I shouldn't say most, have their own practice. Clinical or psychiatric social workers usually requires a 2 years master's degree, which you get a bachelor's, then a master's, then a doctorate, and usually some supervision and work beyond that, sort of like an internship. And so most of the people with everyday personal and family problems, about half earn the National Association of Social Workers designation of social worker, of clinical social workers. Now, counselors, anybody can call themselves a counselor, but we have, for example, marriage and family counselors, which specialize in families' relations. Often clergy will provide counseling to many, many people. Abuse counselors work with substance abuse and with spouse and child abusers and their victims. Mental health and other counselors may be required to have a 2-year master's degree. Now, in a lot of cases, you don't have to have it say you're a counselor. You must have your doctorate and your license to say you're a psychologist. Most school counselors have their master's degree. In our school district, all of them have a master's degree. When we look at preventing the psychological disorders, we look at resilience. How do we build that? There's individual resilience factors and there's community resilience factors. So we look at building those in people. Resilience is the idea that we can deal with aversiveness and still come out on top. And we look at mental disorders. Some people can deal with just a very small thing and it creates mental disorder. Other people go through horrific things that most of us can't imagine and they still become resilient. And that's, a big thing that we want to do is prevent these psychological disorders, looking at those risk factors and trying to eliminate them, looking at not the risk factors, but the positive side of that, which is the protective factors, and trying to increase them. Community psychologists look at this all the time, as long as individual counselors. How do we put the balance into the protective as opposed to the risk factors? Okay, we are going to leave that here for now. We'll look at the biomedical therapies next time, and we'll see you guys in class. Bye for now.